Thank you again for the invitation. I know we've all seen all the detriments of the global pandemic, and this may be one of the few positives where we get to see and meet with our colleagues on a regular basis. So when Feiruz first told me about the theme, excuse me, of the symposium, X-Files, I thought, well, maybe I should talk about aliens in the orbit. And we all know that aliens come in different sizes. There's small ones and medium-sized ones, and there's large ones. But if we look at the definition of aliens, it's usually, if you look in the dictionary, coming from another world. Another definition of aliens are differing in nature or character, typically to the point of incompatibility. And that's going to be the topic of our talk today. So orbital aliens are foreign bodies that we see. And for many of you probably thought this talk was going to be about parasites or something like that. And I think, the Indian colleagues probably have the most experience in that. So for me to give a talk on that would not be appropriate, but we do see some foreign bodies, and, foreign bodies comes in different shapes, different sizes, and different compositions. And if you look at the compositions, we can usually break down them into two broad categories. There are organic foreign bodies, which consist of wood and vegetable matter. And then there are non-organic, which typically can be metallic or non-metallic. And non-metallic ones consist of plastic, glass, and fiberglass. So in general, foreign bodies fall into some typical rules that we follow. Most everyone would remove an organic foreign body. These are typically decomposed. They can harbor fungus, and they can lead to problems if not removed. I think for metallic foreign bodies, most of the time we will leave them if they're not causing functional problems. What about the category of the non-metallic, non-organic, the plastic materials? Well, as you all know, we put implants in the orbit, and these are typically some sort of non-metallic plastic or synthetic material, and these can be very well tolerated in the cases of fractures. So I think in large part, these fall into the category if they're not causing any problem, let's leave them. What about imaging? Well, I think the gold standard is usually the non-contrast CT. MRI can be useful, maybe not as an initial screening test because we don't know if there are any ferromagnetic elements, but it can be useful for organic materials. Angiograms should be used to rule out any vascular involvement, particularly with larger foreign bodies. And then plain films are usually used for screening. For example, in cases where you don't know what could be in the orbit, you get a plain film to determine if there's any ferromagnetic elements, and then you proceed with any sort of additional imaging. Well, let's look at a small foreign body. So this is a 14-month-old boy who presented 2 days after swelling, with swelling after play with siblings, and the mother noticed that he has vomited twice since. And I don't know if many of you probably do have children, and sometimes they play on their own and in the room adjacent to where the adults are, and you hear a lot of playful laughter, and then suddenly everything just goes quiet. And then a couple seconds later, one of them starts crying very loudly. So this is what happened to this mother. She didn't witness it. She didn't know what happened, but she did know that something happened. Of course, talking to all the other siblings, they all deny that anything happened, but the child starts vomiting a couple times and his eyelid starts to swell. And on examination, he has good extraocular movement. His visual acuity is in fixes and follows. And I asked the mother about this little red spot here, and she said, oh, no, that's not an entry wound. That's a little nevus that he has. So that's not anything that would raise any suspicion. And here it is a little bit on higher view, and you can see that's a nevus, but the lid is very swollen. There's discharge and possibly a little bit of hypoglobus. So I think the suspicion that there may be something going on here is quite high, given the systemic involvement with the nausea and the vomiting. So we did order a scan. And this is a bone film of a plain CT scan, axial view. And you'll see, well, things look pretty good. There's no obvious foreign body. And there may be something here. This looks kind of like a bone spur. Is that a bone spur? What is that? It's along the roof of the orbit. And then on 3D reconstruction, you can see that this does not really look like anything that could be a bone spur. This actually looks like a linear object. And you'll notice that this is very close to bone density. So whatever it is not metallic, but it's probably something that has very similar characteristics to bone. So we decide to do an exploration. And we took the patient to the operating room, and immediately we try and look to see, is there any sort of entry wound? So we look in the upper fornix, and we do find that there is a penetrating wound in the upper conjunctiva. So very likely that leads to high suspicion that there is something in there. And then because this wound is so small, we end up making a lid crease incision, subperiosteal plane, tracking along the superior roof of the orbit. And lo and behold, we find a graphite segment from a pencil. And we have to ask ourselves, well, are pencil tips organic or are they non-organic? We know that graphite is probably the largest component of these pencil tips, and to me that's probably kind of a non-organic source, but there is small amounts of clay that is located in the pencil tip, so they're kind of a mixture of the organic and the non-organic. So let's move on to medium-sized foreign bodies. So this is a 43-year-old surfer who was in Mexico surfing and got knocked over by a rogue wave. And it just so happened that his surfboard hit him just above his left eyebrow. And he didn't think anything of it. And he went to the local emergency room and they saw laceration above his brow. And they closed the incision, and he came about a week later to us for suture removal. So here he is on presentation. You can see he's got a linear laceration above his brow. But his lid is swollen, and you can see that his, if you look at his vertical globe position, he definitely has hypoglobus by a couple millimeters. And we start to suspect, well, that's really more hypoglobus than is out of proportion to what the swelling is, and we decide to get imaging. Here's his extraocular movements, and the other thing that tips us off is, well, he doesn't have full up gaze. Down gaze is good and side gaze is good, but his up gaze is limited. He actually has enophthalmos, which is a surprising thing in his left eye. So it goes maybe a little bit against what you might think. If there's some foreign body pushing his eye down, wouldn't he have proptosis or exophthalmos? But his eye is actually in. So here's his coronal imaging. You can see anteriorly, you start to see this, again, bone density kind of radiographic characteristics. You see this linear line that extending further into the orbit starts to assume this V-shaped characteristic. So it looks like starting from the back of the orbit, it kind of wraps around the medial wall, comes down on the floor, comes back up, and then we see the tip of it right here along his superior orbit. So not knowing what this is, we start to feel, and you can actually feel along his superior rim, there's a little palpable foreign body. On axial imaging, you can start to see, again, this very oddly shaped, weird location of this, what appears to be some bone density object. So we take him to the operating room, and we make a lid crease incision, and this is his, the larger arrow here points to his supraorbital rim, and just below that you start to see this object, this what appears to be a shard of fiberglass. So we start to slowly pull this out of his orbit. Here we are about halfway, and here's the entire shard of fiberglass as it exits, and you can see that it has this curvilinear orientation, and it measures about 55 millimeters. And we're thinking to ourselves, well, gee, the orbit's only 40 millimeters. How do we get this 55 millimeter object in there? Well, naturally, with the curvature of the fiberglass, it kind of wrapped around the entire orbital apex. He had a nice result. His vision was intact, and you can see on up gaze and down gaze, he did quite well. The way surfboards are made, however, is that they usually have a core of styrofoam, and they have a fiberglass coating around the styrofoam. And what had happened with him, the little tip of the surfboard just hit his orbital rim below the surface, and a shard of fiberglass had sheared off, and it's almost like peeling a carrot, where the tip of the carrot just goes in, and then the board with its momentum gets pulled away, and that shard of fiberglass had the effect of peeling and going around the orbit. And lucky for him, it avoided any major neurovascular structures, and his function was intact. So let's go on to the large foreign body, which is the last the case that I have. I don't know about how many of you had heard in the news that several years ago we had a lunatic that was actually targeting homeless men in San Diego and driving railroad spikes through them and killing them. And it was such a tragic event. The man was apprehended and is now serving a life sentence. But we happened to see, unfortunately, one of the victims of this tragedy. We had a middle-aged male present status post-assault to our emergency room. He had altered mental status. His primary trauma survey revealed stable vital signs and intact, airway, breathing, and circulation was fine. His secondary trauma survey, however, did show the findings here that we'll discuss. Because of his unresponsiveness, vision was unable to be checked. He did have fixed and non-reactive pupils. His right eye did have motility. The left eye was completely ophthalmoplegic. He did have proptosis in the left eye greater than the right. And his undilated fundus exam did show the right nerve to be of normal limits. However, the left nerve was pale and edematous. Here he is on presentation. You can see here that there's this transverse foreign object that was driven in from the left side with the indentation. And this is the bowing of the right side, which is the tip of the spike, here shown in side view. Here is the tip of where it was driven in. And this here upper asterisk was an attempt to drive the spike further. And luckily for this gentleman, that was unable to be done. And he did survive this incident. This is a CT scan showing extensive artifact here. And this pretty much precludes the use of CT as a good imaging device. So this is the one case where plain film could help you. And you can see that this foreign body is completely outside the cranial cavity. And this is even further accented here. You can see the horizontal foreign body completely located behind the orbits. The upper cranial vault is fortunately intact. So what goes into removing something like this? We did perform preoperative cerebral angiography. And just to orient you here in the center, this is what a normal angiogram looks like. You can see the ophthalmic artery here branching off the internal carotid. On the right side, this is the object. This is the ophthalmic artery, which did have some circulation. And on the left side, it was completely missing. The ophthalmic artery circulation was completely cut off. So there are some preparations that's required to removing a large object like this. There's a Mayfield holder to immobilize the cranium. Both carotid arteries were isolated and with possible ligature if needed for either side in case there was a large vascular event. The wounds cutaneously were extended to isolate and expose the surrounding bone to facilitate removal. This is the entry point. This is the exit point. This is where we show removal of the actual spike. And we do have video as to how that occurred. So because it was wedged in so firmly, a blunt malleable was needed to free it up. And here is the spike being removed. You can see there's a large transcranial defect now, just a very small arterial pumper. And with the endoscope, you can actually visualize this defect across the entire transcranial space. That's some fibrin glue being applied. Here's a diagram of what the spike looked like. I'm sorry, this is in inches. It's about a 7-inch spike, which is about 17 centimeters in length. And this is the photo showing the defect. Repeat imaging did show patency of the right ophthalmic artery. Unfortunately, the left was completely occluded. So we did have some hope that there might be some vision in the right eye. How we filled the defect was it was packed with abdominal fat grafting. and then skin closure. He was kept sedated, and his pupils did remain unreactive, non-reactive. All the cultures were negative from the wound site. Here he is at 1 month. He did have bare light perception in his right eye and left eye. He had complete ptosis and ophthalmoplegia and had no light perception. Unfortunately, he did lose vision 3 months later in the right eye and was left with no light perception in both eyes. You know, the follow-up with this gentleman has been that he did maintain his mental status. However, he did have complete loss of vision in both eyes, and it's just an unfortunate tragedy for this gentleman. So in summary, orbital foreign bodies do come in all shapes and sizes. Good results can be obtained with removal. Sometimes, but not always, vital structures are spared. And I'd like to thank the All India Ophthalmological Society and Dr. Feiruz for the kind invitation to speak. Thank you very much.